what we're trying to do here is we know that at this point in time that we have basically cardioplegia, as Courtney said, you know, even at her institute, you had 3 different types of cardioplegia going at one time. And, you know, you go to multiple institutes across the country and it's like the wild, wild west. We had a cardioplegia. We started off today with cardioplegia and we're going to end the day with cardioplegia. Or we're going to have like a 5-minute segment, which Courtney kind of has already given her her segment. And therefore we're going to let Nick and Scott give their presentation also. So what we're going to do is, again, you know, this is a great little illustration of where we are, you know, with cardioplegia. And I don't know why I'm not getting my questions up, but so Brian, do you have the question there? I'm sorry, but I thought I had the questions on there. Hang on, let me see if I can do it this way. Should be running at this point in time, but it's not. Brian, do you have the questions that you can pull up on the screen? Hang on, it's running right now. Maybe it'll run here. Hang on. Okay, what are the clinical benefits of using all blood in single dose versus classic Del Nido? Are there concerns with using all crystalloid cardioplegia in excess of hemoconcentration? Cardioplegia poll, who is using NPS all single dose? How many centers are using some form of single dose cardioplegia? What is appropriate current interval for redosing? If using a single dose strategy, what is your blood crystalloid ratio? How many cardioplegia protocols are there at your hospital? Who is using syringe pumps to deliver cardioplegia? So those are some of the questions that we're going to ask. And I'm going to let Scott, are you on board here? Yes, Scott's
yes,
there.
Sir.
I'm going to let him go ahead and give, you know, a little brief scenario. And then I'm also going to let Nick give a brief scenario. Then we're going to go into an open question, which will be directed, and each one of the panelists can give their own. And I've already got some questions from Courtney's presentation that I'm going to ask her. So, Scott, give us a little bit of your history with the cardioplegia and where you're at today.
Okay, thank you, Ty. So we've been working microplegia for 15 years now. We started using the Quest in 2004 at our institution. We were initially using the formulation that Quest was kind of giving, standard mag and potassium delivery. Around the time with Del Nido coming out in about 2007, 2008, 2009, we looked at actually using Del Nido. We already had the Quest machine. As we said, we're using a Ferrari for cardioplegia, but yeah, we're wanting to go back to a crystalloid-based solution. We had a discussion with our surgeons, and they always gave us a reason of why we couldn't use it. So we finally were able to get them to use the solution and had good outcomes. We did eventually start doing a study. When I went to another institution, I was able to formulate the study. So I'd like to show some of the information that we were able to gather from that study, if I could here.
Okay.
Let's see. Share screen. There it is. All right, here we go. All right, so this was done about 5 years ago when I was at one of my other institutions. We call our microplegia DNA. Just 3 guys who kind of came up with it. And we wanted to look at it prospectively against Del Nido's solution. So we also looked at multiple variations of actually dosing from single to multi-dosing based on this. With, again, back to should we be using microplegia? We know the evolution of cardioplegia. The evolution has come, you know, all the way from initial when we started first doing heart surgery to where we just clamped. We did electrical fibrillation, which we found out was really bad for glycogen stores. We then started moving to cardioplegia, from anesthesia. They were giving cold crystalloid up there with a bit of potassium. Then we moved to actually putting it onto the pump to different ratios from 1-to-1, 4-to-1, 2-to-1, and then finally moving into a Del Nido microplege, mainly on valves in adults. There's always been a stigma on using it on cabbages. We have actually ventured into this area and wanted to show some of the data and information on these actual cabbage cases. So again, back to why the surgeons always said we could. There was always a perceived limitation with the influx of the calcium during asystole. We know that during asystole, calcium will follow sodium actually through the passive channels, and therefore then creating arrhythmias postoperatively and possibly leading to the stone heart, especially over a long period of time, not delivering more cardioplegia. Del Nido, obviously based in crystal and plasmolite. Why? It has no calcium in it. You get nice calcium washout through the cells, and you have that nice, rest during that time, making it possible for a single dose. So this is a little different from Courtney's, not much. We don't have much variation, but you can kind of see the different cardioplegias and then what we were using prior. We were using a 4-to-1 system when I went to that institution for a period of time, and you can see the plasmolite, potassium, multiple different things in there, and then you can see the Del Nido solution. What we have done a little differently is we wanted to up a little bit more of the mag. We were actually at a 5 gram at one point in time. We've now come down to 3 grams. A lot of the surgeons were complaining post-operatively of hypotension, which we know that magnesium, high doses of magnesium will lead to some excess hypotension and contractility. So we actually reduced that down to 3. We increased the lidocaine up to 200. And we kept the bicarb and the mannitol roughly equal as well. That was going to be our strategy that we employed and that we were also using over at Baylor, Dallas at that point in time as well. So here, I'm not going to go through the exclusion, but here was our inclusion. We wanted to look at only 100 patients. They were going to be elective cases. They could be cabbages. They could be single valves, cabbages or valves. There was no high or low, just as long as our biggest problem was finding a group of people with a normal troponin I values. Imagine doing heart surgery on patients with normal troponins. They're actually more challenging to find than you would think. Normal H and H, a little higher, than 27, and good creatinine levels as well. So here's the meat of it. This is what we found out looking at the troponin I's. I researched some other studies that looked at microplege, looked at Del Nido versus 4-to-1. This is how I came up with the time frame of 2, 8, 16, 24, 48, 72 hours. Those were in other studies, so we could relatively compare this information to those studies as well. You can see on the graphs you have the red, the orange, kind of the blue, and the yellow. And the single dose all blood formulation that I was showing you is actually the red line. You can see the troponin I releases on a single dose have actually the best troponin I's, as even opposed to looking at the all is going to be the yellow one. I'm sorry, the multi-dose. Yes, I'm sorry, the yellow one, the troponins are even higher with multi-dosing, even with the same cardioplegia. Same as with Del Nido as well. The single dose Del Nido is still a lower troponin I release as opposed to multi-dosing. So the theory there is maybe oxygen-free radicals, a high hyperoxia as well, that it's actually leading to cellular death. So there's no real understanding of why that's happening, but we did see a better protection based off troponin I's with using an all blood formulation in this study. Also, just real quick, because I know everybody's been talking about, is AKI and hemoconcentrator usage. You can see the amount of hemoconcentration that we actually had to use with Del Nido as opposed to the microplege. Well known, obviously, we're not giving an extra crystalloid. There's no reason to have to hemoconcentrate, hopefully reducing AKI postoperatively. Then you can see our volumes on average with Del Nido cases. We pulled off about 2 liters, and the other ones were actually a little higher, but you can see the number of cases were actually 10 times less. So what does that show for cost savings? Medical City at that time, we were doing about 500 cases. You can extrapolate that out for how many hemoconcentrators we'd use. On average, a hemoconcentrator probably costs an institution about $100. It's $32,000 just in hemoconcentrators over maybe a whole year based on 500 cases. If you still had to use some on a normal microplege, you're looking at $2,500. So in theory, we saved about $30,000 per year. So that also with the 50,000 on the very bottom, that was on the waste solution as well. That was on another slide, but I wasn't going to introduce it here just because I had a short period of time. And then morbidity and mortality, really no difference. We had a couple patients expire from the microplege, but it was actually directly related to it. One had a postoperative GI bleed that we had a complication of and was undiagnosed prior to the surgery. And then there was some patient, he had expired at home, but there was no cause. We don't see any higher incidence of stroke, so the higher lidocaine does not actually induce any type of seizure activity. And the reason we looked at AKI, another perfusionist in the country is using this plege as well. He was having a little higher AKI issues. We didn't see anything there. So let me get back out of there, Ty. Let's see. Stop share. There we go. So hopefully that at least kind of gives some good information of where we're looking and what I have seen over the years and what we've kind of looked at based on what Courtney was saying as well, looking at troponin levels and hopefully kind of getting a better understanding of what the myocardial protection looks like based with microplege and a crystalloid-based formula.
Thank you, Scott. That was excellent. And I've got a lot of questions from that. So, Nick, we're going to let you give a brief introduction of what your model of cardioplegia is and what you're doing with it at this point in time.
All right, thank you, Ty, and thank you, everybody. And I also want to thank Debbie for inviting me from Quest. Courtney, I'd like to say hello to you, and if you could give a big shout out to Dr. Faber, I'd appreciate it. He was
I will.
So at our institution, we're using a modified, I don't have any slides to show you, but we're using a modified Del Nido as well. The only difference that I really see that we don't add to ours is the bicarb. Everything else is about the same. We got basically 30 to 32 mLs of mannitol, 2% lidocaine, 13 mLs, and 4 grams of mag. And that does push the pouch to its outer limits. I believe the pouches only hold, correct me if I'm wrong, Deb, 50 mLs. This comes out to be 53. So it does push through to the heat exchanger a little bit, but that's fine. And then in the arrest side, depending on the perfusionist and depending on the case, some people put in 80 milliequivalents, other people put in 40. I generally just throw 80 in there. And like Courtney, we mix our own Cardioplegia as well. I got it in writing from our pharmacy team for the same reason. Typically speaking, we use the KBC protocol. I don't know if anybody out there is familiar with that, but it works very well, and it's so simple. And we give between 10 and 15 mLs per kilo, depending upon the surgeon. As far as intermittent doses, we generally go, one surgeon goes 30 minutes, another one will go 45. We tend to all remind them at 45, except for the individual who wants more. Most of our guys are using all antegrade. We have one that uses retrograde for just valves, and our intermittent dose is usually about 300 mLs per kilo, or 300 mLs total. And like everybody else, we've had great success with it. Prior to Del Nido, we were just using microplegia, the old-fashioned formula that we've been using it for 15 years as well, like Scott, but just the mag and potassium. And that worked well, and we would give intermittent doses between 15, 20 minutes. But we were also had another surgeon use nothing but HTK, custodial. And I got to admit, I didn't really like the custodial. I didn't like having the hemoconcentrate on every case. And if you had a lot of heart failure like we do here at Tampa General, you had to be very careful with the crystalloid because your reservoir is always full. The Del Nido is nice because it's blood. It's blood microplegia. We don't have any crystalloid other than the meds themselves that get to the heart. It's a real nice way of doing cardioplegia.
Thanks.
We do not use syringe pumps. We only have really one cardioplegia protocol. I told you about my blood crystalloid ratio. I told you about redosing. And we do use the MPS, obviously. And I think I've answered all the questions.
Okay. Well, Courtney, now that we're getting to the questions, and anybody that comes up and sees any questions on the screen, please bring them up. Courtney, I have a question. In your study that you showed earlier, you showed the low risk patients and the high risk patients, and how y'all more or less but you look at your slide with your blood usage on those slides. You saw almost a 40% blood usage in the low risk patients and almost 60% in the high risk. What do you contribute your blood usage to with your protocols? I mean, it seems like you have a high blood usage at your institution.
Yeah. So
in other words, you need to work on something.
No. Okay. So the study was started in 2016 and 2017, and it's interesting that you bring it up, because we actually have changed a lot of things over the last 4 years. Besides surgeons and besides cardioplegia, we had a huge blood utilization meeting, and we were actually almost having it weekly at one point with all of anesthesia, all the surgeons, and one of our surgeons had us introduce, we weren't wrapping, so that was probably one of the biggest things. And now when Dr. Faber, speaking of Nick, when Dr. Faber came, he doesn't retrograde prime, he actually does it through the venous line. And so we go from the venous line through the whole circuit, and we can actually get a very good decreasing in our prime volume. And so it's probably something else that we could look at. But at the time of the study, when those numbers were pulled, those were probably the true blood utilization numbers at the time. Now it would be much, much lower.
And at some of the institutes, basically the Keystone protocol, Nick, Scott, I'm very familiar with, or Nick, you're using more or less the Keystone protocol. And they are having the pharmacy do their syringes, because we couldn't get by at the different hospitals at Atlanta Medical. We couldn't get by credentialing perfusionists to draw drugs for the cardioplegia. They made a huge issue of this. How did y'all get by this? Scott, are you drawing your own drugs for your cardioplegia also?
Was that to me, Ty? Yes.
Yes.
Currently, we are drawing our own cardioplegia drugs. We have been since we started this. We did go through a time where we were actually hand injecting. The MPS had actually left our institution for a period of time. Our outcomes did suffer slightly. So we did go back to the MPS from everything that Courtney had presented and the safety and the delivery features. So right now we are also looking to actually have the pharmacy make it just to have consistency. But right now they're not compounding as well. They need to check the validity of our cardioplegia. So currently we are still drawing up our cardioplegia. We do as well. Some other people have discussed it, but for dosing wise, we're doing a single dose on every antigrade only, 1200 cc's cold. We're using the 10 core and not the 16 core. And, no differences in temperature based on the 16 core. So we actually will do the 10 core, to be honest with you.
Scott, that's a lot of institutions, I think, aren't allowing people to mix their own or put additives. Did that have to go through a lot of scrutiny with lab or management or?
Yeah. And what legal, do y'all have legal document for your hospital to do that?
We do. We actually spoke with the top of pharmacy and legal. Everything is written out just like everyone else here that does cover us, and everything has been off with our institute this time.
Fantastic. I wish we could all do that. With Deborah, since you're on the line here too, with the new MPS system, where What changes are going to be made? I know you had a great discussion on that today. How are these changes going to help the perfusionist with the new system versus the system that we have now? I know you went over some of the bells and whistles in the new system, but where do you see the huge advantages of the new your new MPS system?
Well, the one thing that we'd like to talk about is we're looking at time to arrest. There's going to be an EKG component where you plug in your EKG, and on that independent controller, you're going to be able to study at what point do you get arrest, and what is that going to do for us as a perfusion community. That compounded with auto start, which is eliminating the human, essentially going up very slow, very carefully on the flow and not closing the aortic valve fast. We are very curious as a company to see what that's going to do for our profession. We don't know yet.
Okay. My other panelists, do they have questions out there? Susan, I see your head nodding.
I have a question for you and your group. If you're going to bring in the MPS, the Quest, to your group, and you have maybe 7 to 10 perfusionists in your group, what would you do to make them feel comfortable operating the system and troubleshooting and that sort of thing? What would your system? What would you do?
What would your training protocol be as far as any of you?
I'll jump in on that. I have a team of 12 here at Tampa General, and the device itself is intimidating looking, but it's also very simple. You run 1 or 2 cases and you're fine. I will tell you this, I have seen the MPS 3, and I saw it when it was in the stages of still at the home office of Quest, and it's even more intimidating looking, but yet simpler to even use than what the MPS 2 is. So, it's not that big of a learning curve. It really isn't. Once you get used to it, and I'm honest, it's probably only 2 or 3 cases, and you'll be fine.
That's what we allot training. We allot 3 for perfusionists for clinical training.
I'm sorry, Debbie, I didn't get that.
Oh, we allot 3 clinical training cases per perfusionist. That's on our average. Now, obviously, there's a learning curve in every department, and we're happy to help, where the curve doesn't apply or applies one way and not the other. But on average, when we do the calculation for how many disposables we're going to send in, it's 3 per perfusionist on staff.
Okay. Being that we instituted this sooner than Scott and Nick, I can speak to that. Quest was very helpful. They came out for over a week and actually asked if we needed more time, and we're sat there for every single case with the perfusionist on the case. Something else that we were able to do is just take one set and have it set up in the pump room. So if anybody was nervous, they could go in and play and prime it and try to set off bubble alarms or pressure alarms or whatever, and try to get some troubleshooting done when you're bringing this in.
Yeah, I'm going to go back with what Nick said. So far, I've gone to, like I said, two different institutions and brought the machines into both institutions. So we've trained probably about 20 different perfusionists on this. Yeah, it is very easy to use. It's very user friendly. It does look intimidating, but there's so many features on it. Once you run it a couple times, it's a little different than a standard 4-to-1. Most people, after using a 4-to-1, they want to go up nice and slow. They don't build up that pressure with the aortic valve. That's usually just the biggest issue with understanding what your additive and arrest agents need to be with your modifications, which we have tried to simplify that down to 1 single dose and not really bring into any other issues or factors. You give 1 dose with 1 setting. Once you give it, you're done. We're running up to 120 minutes now on cabbages and valves and having some, excellent outcomes at this point, to the point to where my surgeon wants us to write another paper on it and get it published to show our outcomes based on that. So very easy to use and very quick to get your staff up and trained with, I believe.
I will say this, if you're going to buy it, do your research, because the hardest thing about it is cleaning it. Changing that water is not easy. I think everybody will agree with me on that.
We are working on something that is going through FDA approval also that requires no disinfection.
That brings up another question. How's everybody using it with heater coolers? You're using the ice bucket or hooking it to a device?
I think Courtney said she's gone straight to the ice bucket.
Right.
Mm-hmm. Can I jump in, Debbie?
Sorry, go ahead. I'll wait.
Okay, sorry. We're using the CardioEquip. Sorry, we're using the CardioEquip, and actually, instead of us actually leaving it on conserve ice, we actually turn it to continuous ice for the actual case. And using the case, we haven't seen really any ice blocks being melted. We still get down to about 8 degrees or so. We see that as being sufficient with our cases, even up to 120 minutes. Cleaning wise, we go through the standard protocols of cleaning. Again, they are a little bit cumbersome, but we're able to get that done and taken care of.
We use the CardioEquip as well. I do not put it on continuous. I use intermittent, and I will turn it on continuous if it's going to be a short case, but a longer case, I'll leave it on intermittent. And I use the CardioEquip, and I turn my ice off on the Cardioplegia side. Scott, do you guys have the turbo nozzle on yours?
Yes, we do.
So unfortunately, that will, over a long case, deplete your ice block, but it hasn't really been a problem. And we get down to about 8 degrees as well.
Yeah, we've noticed as long as we turn it off, if you're doing a cabbage while they're harvesting vein and not letting it continuously run before the actual meat of the case, we did see some issues with the block being melted then. But on a standard cabbage, we can do 2 or 3 cases back to back and still have sufficient ice for all cases, just as long as you are being cognizant that the machine is off when not being utilized.
Just keep in mind, everyone, the Quest was designed originally back in the 90s to run with the hypothermic reservoir, aka the ice bucket, the brown bucket. So we've had to evolve over time when specifically people started using the heater cooler, which is off label with our device, and then with the CardioEquip. We have seen higher water temperatures coming out of the CardioEquip. So we came up with the 16 core disposable. So that will get you back to the normal lower temperatures you see when you're using the 10 core with the ice bucket.
Okay. This morning, okay, Bill, you got a question?
I'm reading some of the questions off here, Ty.
Sure.
I'll just mention, somebody asked about hot shots during your first dose. Do you give a certain amount of hot and then switch over to cold? And the other question was pressure control when you're giving down a graft. You know, I don't know what your surgeons do, but some surgeons want to go at a certain flow and see what the pressure is. Some people want to go at a certain pressure and see what the flow is down a distal graft to see what's going on. So those were a couple of questions from our viewing audience.
Going down the graft, I have a surgeon that actually one that wants it to go at 50. And not a problem at all. We just turn it up to 50 mL. Sometimes he asks the pressure, sometimes he doesn't. I also had another surgeon that would ask us to dial it to a pressure of 110 and then want to know what the flow rate was. And same thing, it's, not a problem. They're not always happy with the flow rate, but that's not my problem.
I think. Go ahead, Scott.
Sorry, Ty. What was the first question there, Bill? I missed the first one. What was
whether or not you're giving one dose, whether or not you're doing a little bit of a hot shot before you switch over to cold.
For our induction, we do not give any hot shot initially. We set the machine at as cold as possible. Let it run. We give it at 1200, and we do not give any hot shots post either before the clamp comes off. We just take the clamp off, let the systemic warm blood reanimate the heart. It usually takes about a minute, maybe 2, to reanimate. Most of the time on cabbages, we're off bypass in about 5 minutes from the time the clamp comes off till we're actually off bypass.
And I think Nick in the Kennestone protocol and the KVC protocol, they do give a hot shot right before, about 1 30-second hot shot, don't they?
We give 400. Well, I should say we do that for all cases. Certain surgeons at my institution just take the clamp off and say, there's your hot shot.
Yeah.
Other surgeons will go ahead and give about 400 mLs of blood only. Sometimes I leave my additive on just because of the lidocaine that's in there and the mag. But again, it's 50-50 at our institution. We do not induce with a hot shot and then switch to cold. We do the same thing Scott does.
So Nick, when you give that last little bit before they take the clamp off, you're adding no potassium to it, right? You
Correct. I turn mine off. I do turn my potassium off to 0, and that's the beauty of the Quest. Courtney touched on that. You can change things on the fly. It's very nice.
Right. Well, I think the original thought, behind the hot shot, and maybe it's been disproven, is you warm the cells up, but you give them an energy substrate, but you keep the heart from pumping for a little while you got that warm oxygenation taking place again. So they build up energy stores. But that was the original thought behind that. So.
I like I said, I like to leave my additive on. Everybody knows that, magnesium is additive end of the heart. So I like to leave that on, turn the K off. And the fact that there's lidocaine in there too is another bonus.
And Bill, the other thing is that you can do a hot shot and then immediately start cooling, and within minutes you'll be cold, and vice versa. If you've warmed your pleege up and given a hot shot at the end of the case, and then an emergency comes about and you have to cool down immediately, it's within 2 to 3 minutes that you're cold.
Yeah, I found that to be spectacular, and the times that I've used it, really, you can switch over so quickly and back and forth. Spectacular.
I have to say that actually happened to me yesterday. It wasn't a single dose protocol, but we were doing a dissection, and we had to do the patient needed a graft as well, and we're doing the bypass graft, and he tells me to give the hot shot. So I start the hot shot warm, and he goes, no, I got to do my graft. So to jump back, put it back to cold, give a little bit more cold to keep the heart cold just during that 15-minute period, and then warm it right back up to give it. The Quest doesn't have any problems going between those two. It's very easy to go in between.
Very good.
And I think to touch on the note about the auto regulation for pressure, we also have a feature called auto regulate. It's like cruise control. So if you're going to be running down a graft and the surgeon wants it at a certain pressure or flow, you can go into auto regulate mode, and it'll control that based on what the varying, what's going on at the field. It works especially nice in retrograde as they're manipulating the heart and the coronary sinuses all over the place. So it'll allow you not to blow up the coronary sinus.
Coronary sinus.
Oh, it's flow and pressure?
Yes.
Flow or pressure, you can choose?
Yes.
Okay.
Yes.
Do any of you still have surgeons that are monitoring myocardial temperature?
None in Tampa.
I did when I was at the other institution, but none currently now. No.
Not at the current, at one of my hospitals where I actually pump, no, but at one of the hospitals that I manage, yes, they do routinely on every case.
Do they put the temperature probe in the same place every time?
Usually.
Mm-hmm.
I hope so.
It seems like they put it in a bucket of hot water to me.
Yeah, always seems to have discrepancy.
Yeah.
There was some concerns about some of the presentations this morning about, I know, giving one dose. I know, Scott, you hardly ever put a retrograde cannula in at your institution, and
No.
I think that's wonderful because it just takes time, and a lot of the surgeons don't know how to do it. But what we're seeing is, I guess the concern was this morning that you're giving one dose and you're basically got a warm heart throughout the whole case, even though you have a complete arrest, but you still have a warm heart. Does that concern you?
No, that really actually doesn't concern me. A lot of the papers that I've read, just giving a chemical arrest will actually reduce the metabolic demand by over 90%. So if we're looking at just temperature, it's really only 10% of the myocardial protection as long as it's chemically arrested. I think with the amount of lidocaine and the amount of magnesium during these arrests, those are keeping the cells from going into any type of anaerobic metabolism. That's why we're not using glucose. We don't need any glycogen stores. We're not using anything to reanimate. Currently, again, we're not looking at temperature. We give the one dose. We're doing it on cabbages. I did a left main the other day, 99% left main. We went 90 minutes with a single dose of 1200 degrees or 1200 cc's. And clamp came off, heart reanimated, came out of the room on very minimal drips, maybe like a 0.02 of epi and 0.02 of levo. And we were out the door. So no, it really does not.
So each of you have pretty much similar protocols, but Nick, you're doing the Kennestone protocol where yours is patient dose related. Scott, you're giving the pretty much same dose to every patient. Courtney,
Yes.
You're pretty much same to every patient also, correct?
Mm-hmm.
So
yeah, 1200 any patient. It doesn't matter what their weight is. We are not weight basing ours.
right. Okay.
I think it's important for the audience to understand anything they can do with crystalloid, we can do in a blood-based environment.
Absolutely. We see any more questions coming across the board, Susan?
18 hours.
It's 5 o'clock somewhere.
I had one also. And does anybody use the adenosine in their additive pouch yet?
Very good question.
We have an account in Birmingham, Alabama that uses it. They inject it on the initial dose.
We had a surgeon back in the day who used adenosine. We looked at it. We didn't really see the need to put adenosine back into the cardioplegia. It has such a short half-life. Delivering is such a challenge with the MPS as well. I know the new cores also are able to deliver it. We have to hand inject that. We're trying to take out all hand injecting and just letting the machine do it. That way we have consistent delivery. We've seen such great outcomes without using adenosine at this point that we haven't really gone back to adding adenosine to the solution. But obviously there are other institutions that are using it. So it would be interesting to see how their troponin eyes look and what their myocardial protection looks like.
Mm-hmm.
We don't use it, but I like it, and I like to have it available, especially when a surgeon says, hey, I just need to quickly arrest this heart again. If they got a bleeding distal or something, or even bleeding proximal, whatever, I'll just put it right into my manifold. And maybe I won't get a real good arrest, but it'll quiet it down quick enough, especially with the short half-life. It's kind of nice.
Mm-hmm.
There's going to be some good presentations tomorrow. I want to hear about them and see what they're doing with the adenosine at that point in time. I think it's going to be very interesting.
I agree. The one thing also is you can put adenosine into our circuit by with the 16 core, it has a lured port that you can add a stopcock or inject it directly. Or if you have the 10 core, you can put a stopcock between your additive outlet pouch into the bottom of the heat exchanger, and it'll mix.
Mm-hmm.
Okay. Any other questions out there at this point in time?
There was another question about the troubleshooting issues. I think when you're learning something new, the best thing is to always ask, well, what kind of troubleshooting do you need to have? Or what problems have you seen when you're running it?
I guess I'll jump in on that one. So recently we went back again at Baylor to the machines. We did go to the 16 core initially. We had some with the 16 core. We were able to identify what those problems were. I think we were able to fix them as well. The heat exchanger was coming a little loose, and so as we were giving our cardioplegia, it would cycle and open the vent valves. So, there's one way of having to kind of identify why the vent valve is opening. Again, you can clamp the vent line off, and you can still deliver your plege. But, there are multiple different things you can set up in a scenario with your staff even prior, or sit with them during the cases and go over. Really, the machine itself is pretty much foolproof. I mean, it runs all the time. We don't have hand cranks in the room, which we probably should, but we don't. But that's how much trust we have in this machine. So we really enjoy it. We really enjoy using it. But, based on, what problems we've seen, really, those have been the smallest problems. I mean, they're nothing major. And even though it looks, very technical, it is very technical on the inside of the components. Using it has been very user-friendly.
Mm-hmm.
Susan, to address that question, when we came out with it, we found the screws holding in the locking block were a little too short. So we sent out longer screws, and that kept the disposable seal, and you weren't getting that alarm with the vent opening up.
Mm-hmm. Okay.
So I know, Susan, you travel quite a bit, and Bill and Carla, but do you have a lot of travelers? I mean, how do you do the training? I mean, you have travelers, we have travelers come in at spur of the moment, you know, and so how do you go about, I mean, when you have someone that's a traveler coming into your institute that really hasn't run an MPS, you know, we don't really, I don't know how we have the time, you know, you're talking about a 3-day training mode of getting these people ready. You can't really, it's not fair to the perfusionist to throw them into an MPS system. Should travelers all go through some type of MPS training at a facility before, just like ECLS? Should they go in and basically already be certified more or less in MPS technology? Debbie, I'll let you answer that.
We are always happy to do any training that is necessary from Quest's end. I know some of the perfusion groups have their own internal training that people have to be checked off on our machine before they can go into an account and pump the case using the Quest. We are working on our controller for MPS3 will be a training device. So you will actually be able to run a case on the Quest controller before pumping a case on a human in the future. So that's how we solve that issue.
Very good.
But the Quest can be as simple as you want as far as flow.
So that'll be like a training module built into the touchscreen?
Yes.
Training mode?
It'll highlight in orange. And when you're in orange, you know you're in the training mode. It won't run the MPS unit.
I'll call it Trump mode.
Oh my gosh.
But Ty, speaking of training, you know, I have to say what Scott and Nick said about really only needing a couple cases. That's true. I mean, it's like Debbie said, it's as easy as you want it to be. You know, if you have a trainer or a traveler come in or per diem, you know, you can stand there with them during a case or two, but to say that one of these big problems that people worry about that me and Scott and probably Nick, we don't really see, they're probably not going to come up during that 1 or 2 cases. So it's basically training the person on what's your additive, what's your arrest, how to put it in, and then how to run it, you know, and what you're monitoring for. Priming it. It primes up pretty much on its own, but how would you jump back into prime mode if you needed to, if you saw any kind of error? Or how would you reprime your delivery line? Like those things you can run through.
Right. Or how would you I've seen it go down and you had to reboot it. So
yeah.
And that's troubleshooting right there. If you're having to reboot the system, sometimes that's gonna, someone new, that's gonna blow their mind. It did blow my mind when I did it. But so I mean, it's just those are some of the learning curves. So I think having a training module, especially when people have come in, just like any kind of, I don't think Bill Harris would want someone to come in that really hasn't run a certain ECLS device and just take it over at the seat of their pants.
Happens all the time.
I know. And is that the right thing, or is it
Hell
the
no.
right thing? Hell no, it's not the right thing.
Yeah, right. So what I'm thinking is on the Quest, if somebody asked how long does it ramp up if you had an emergency? I know it depends on your buttons that you're hitting and if you're preset. What is the time for ramping up from turning it on?
Turning it on and priming is 1 minute and 45 seconds.
With an experienced person.
Feels like forever.
Yeah, I was gonna say if you have to reboot it, cross clamps on, it's forever. Yeah.
A minute 45, Debbie.
Yeah, it's 1 minute and 45 from the start to the finish. You're going back to the priming cycle. But again, sometimes it's like your smartphone. It's a computer. It'll get stuck. So just, toggle it off and, wait as long as you can wait, 30, maybe 60 seconds and then toggle it back on. And if it happens more than twice, I would pull it.
So it's a long minute and 45 seconds for that surgeon tapping his foot up there looking at you.
Yeah, but those instances are small.
I know.
It only takes one.
Yeah. Carla, you have any questions?
I have another one from from Bipple.
Okay.
So he wanted to know, how often do you have to defibrillate after the cross clamp comes off?
Ooh, very seldom.
Not very often.
No.
Yeah. I mean, I would say probably 5%, if even less than that. I mean, if we have to actually get the paddles out and actually put them on the field, I mean, that's even, I mean, there's something else is going on. We usually maybe have seen some air coming from a valve case going into the RCA or something. That's usually the only reason why we fibrillate, is we didn't get a good de-airing, or there was a small pocket. Defibrillation hardly ever happens.
I also think that's kind of a question of not really what device you're using, but what medications you're using, what cardioplegia solution you're using versus what device is delivering it.
The technique, yeah.
Right.
I mean, with microplegia, I know in our last large academic trial, we had 97% normal sinus rhythm when the cross clamp was removed.
Good.
That's about what they had up there with Dr. William Cooper at Kennestone at that point in time. I mean, pretty much every patient just spontaneously converted.
I think that's part of cross clamp times too. I mean,
actually, it wasn't, Bill. I would not say that at all. I mean, there was an hour and a half, sometimes an hour and a half cardioplegia with one dose, and these patients would boom spontaneously cardiovert. So it really didn't have anything to do with the cross clamp time. Like I think Nick said, it's the type of cardioplegia and the delivery device that you're using. So
no problem on 3-hour cross clamp times, huh, for certain surgeons?
You know, Sir Bill.
No one's answering that question.
Next question.
No, actually, unfortunately, we were in a case the other day with 3-hour cross clamp time. To be honest with you, we gave 2 doses. Our initial dose we ran up to 2 hours, 120 minutes. We redosed again, brought the clamp off. It took about 2 minutes to reanimate, and we were off pump in about 7 minutes after that one. So no, and again, Nick is everybody else. What cardioplegia are you using? What are your subjects there? And how are you delivering it? Those are all those key factors. And hand injection, syringe pumping, probably not the best. If you're micro, I would obviously highly recommend somebody going to a Quest system. It is initial cost, but it's better for your patient.
Mrs. Mott wanted to know if anybody's adding alcohol to their ice bucket.
I add alcohol to my ice bucket every day.
That's my question, Susie Q.
Back in the day when we had the ice buckets, not everybody on our team would do it, but I did. I added ice or alcohol to the ice.
And how much would you add?
It was nice. And I will admit that ice bucket does make it a lot colder than the CardioQuip, but getting ice isn't always the easiest thing.
Sterilize your hands in it now.
Label.
How much would you add, Nick?
I'd add 1 bottle.
1 bottle.
Oh.
Yeah, we did it all the time.
Yeah. It does make it colder, and it conserves the ice.
Yeah. Absolutely.
I vaguely remember something. It might have been an old Charlie system where it actually froze off. I mean, I couldn't get any flow through it. That's how cold it got through the coils that we put in there.
That was the old Bentley coil system that you used to
use.
Yeah, and we basically used it, and it would freeze the coil if it wasn't circulating. It would freeze that coil in there. I guess my question is, if you looking at all the programs and looking at the Wild West show and out there, what would you, if you had something to recommend to these centers and these institutes that are using, some institutes that are using 4 different cardioplegias, 4 different techniques, and you got, a variety of, I mean, it's not just, they're not similar, they're totally different. So, I mean, this system, the Kennestone program, and Nick, I mean, Scott, I haven't seen yours, but it sounds absolutely wonderful. Nick, been to Kennestone, I saw what they did up there, and it was, to me, it was the gold standard. And Scott, I think yours is the gold standard too. How do you tell these, how do we get these institutions more on board, again, standardizing cardioplegia? Because it seems like wherever the surgeon trained, that's what he's bringing to the institution. So it just seems like there needs to be a little bit more consistency in what we do to arrest the heart.
There definitely does, and it is a challenge even for us. It's taken about a year to get everybody to believe and to switch. Usually, we started with one surgeon who, identified that one individual in the institution that's wanting to try a single dose. A cardioplegia solution, whether it's, KBC protocol, whether it's our protocol, that has been shown to work already. Follow those protocols, what they've learned from their experiences. And eventually, as those patients start having good outcomes, you start seeing it. So for us, within just a single institution, it takes time. And that's really all that it kind of boils down to, is how long you're willing to continuously spend in pushing these different protocols, finding the data, presenting the data. I mean, there's nothing you're going to do. So have the data and you're able to present it to the institution, to your surgeons, they will, once they see it, actually want and they will actually want to move towards it. It's a much simpler technique, and that's kind of what I live by, is the KISS, right? Keep it simple. And as long as you can keep it simple, we're down to one formula. We're down to pretty much one dose. You turn it on, you turn it off. My surgeon actually turned around the other day and wanted to know if I was still back there. He missed talking to me. So, but that's the way that it should be. We shouldn't change and try to make it complex. It's already complex. You don't need to add any more complexity to it. So there are multiple cardioplegias out there, and you're right. These surgeons, as they come, they train. I don't really believe they know what's in their cardioplegia. They know that they used it at that institution. They know the name of it, and they're used to it. So they want to bring that to your next institution. So you have to show them and get the data and show why you're using yours and why it's more superior than what they're wanting to bring in.
So Scott, do you, or Nick or Courtney, do you have where, for example, if surgeon somewhere in Kansas wants to bring their group out to look at your institution, you have a training? Will Debbie pick up, Deborah, you're going to pick up the tab for them to fly out there and basically go through his protocol, right?
We have some surgeon-based and team-based training available.
Okay. I can't think of anything else. Anybody else have any questions, Brian?
I think the one thing that I want people to know is the MPS is one of the safest devices on the market. It can handle past, present, and future cardioplegia recipes for any surgeon that walks through your door. It's like a smartphone. There's a little bit of a learning curve, but once you learn it, you can't live without it. It can be as simple as you want with flow and pressure, and then you can add on like different graduate level training, like the auto regulation and volume to be delivered. The Quest is very reliable. I've spent my whole career as a perfusionist using it, and I'm very happy to offer it now to the world, being on staff with Quest. And I'm excited about the future with MPS 3. I think we're going to see things that we didn't know about before regarding auto start and time to arrest. So stay tuned.
We will. We will. Well, again, thank you, all three of you, and thank you, Debbie, for basically, for y'all sponsoring this event. I think it's gone great. Hopefully we'll be live next year by the pool, having our pizza and our drinks at that point in time. I'm going to go get my alcohol out of my ice in just a minute, so therefore I can have that. So again, I want to thank everybody. I want to thank our audience for the questions, and hopefully you've gained a great deal of knowledge. If you want to contact any of these individuals, I'm sure they'll be willing to talk to you. So please, if you have any questions, I believe their emails are on our agenda. Are they not, Susan, or can they contact them there? Do y'all mind if we share your emails with all the people out there?
That's fine.
Okay.